Hello, I am Luciana Rodriguez Guerinea, staff intensivist in the critical care medicine department at SickKid, and today I will talk about liberation from mechanical ventilation in children. So over the course of this talk, we will review what is the current situation in pediatrics, the extubation readiness test, that is the screening phase, and the spontaneous breathing trial, some predictive indices for weaning and how they perform in children, and finally, the latest international guidelines about this topic. So it's well known that early separation from mechanical ventilation improves outcomes, or if we say on the other way around, extubation failure is associated with worse outcome, such as longer stay in hospital and in ICU and mortality. Sorry. Extubation failure rates are low in children, can be up to 15% in neonates, but if we take the whole pediatric group, it is a single digit, usually below 10%. Extubation readiness test, that is a daily pre-trial screening and subsequent spontaneous breathing trial, is a standardized method to assess the ongoing need for mechanical ventilation. And it has been associated with a shorter duration of mechanical ventilation, and in some studies with also a higher rate of successful extubation. But weaning practices in children are not uniform, and the SBT mode that is most beneficial, whether if it is pressure support ventilation or CPAP, it's not well established. Neither it is the duration of the SBT trial. So now if we look at what is the current situation in pediatrics, this is a snapshot of a recent survey we have conducted, in which you can see the SBT itself. The mode of SBT varies widely across the world. There are some institutions which perform the SBT in pressure support, and the level of support depends on the ETT size or the ventilatory circuit, or it fixed. There are others who use a CPAP, or which divide the patient in high risk for extubation failure or standard risk. And there are some institutions that do not have an SBT protocol at all. In terms of duration, the duration can be as short as 5 minutes or even overnight, but the most consistent answer is between 30 minutes and 2 hours. And if you ask why this variability, this is because there is a conception for some people that breathing through a small ET tube is like breathing through a straw. And this is imposed an acceptable work of breathing. So while there is evidence, as you can see in the graph below, that a smaller ET tube have higher resistance, there is no evidence that this has any clinical relevance. And in fact, to use the same example and as it was used in the review I cited here, if you think about the size of the ET tube and the size of the patient, a 3-kilogram infant accepts a 3 millimeters ET tube, whereas a 60-kilogram adult, a 9 millimeter ET tube. That means a 20-fold increase in body size, but only a 3-fold increase in the ET tube size. And as you can see in the graph below as well, this is the imposed work of breathing measured in different age categories: neonate, infant, small child, adolescent, and with different range of tidal volume. This is a bench study, but you can see that overall the imposed work of breathing is below 0.4. And in fact, the conclusion of this study is that this is there is no significant difference between the age group and the ET tube size, and therefore this type of study support or are against the use of pressure support during the SBT, since the resistance that is related to the ET tube is negligible. So if we move now to the extubation readiness test, and I will use the same definition that it was used in the last international clinical practice guidelines. So extubation readiness test is a bundle of items that are used to assess the patient's readiness to be extubated, while the SBT, the spontaneous breathing trial, is a systematic method of reduction of ventilatory support to assess the patient's ability to be extubated. So the screening phase, that is the assessment of readiness to undertake an SBT, is the phase that is less study of an extubation readiness trial. I brought here 4 randomized control trial in children, and you can see that these trials have in common the items that need to be assessed in the screening, such as FiO2 and saturation, the level of support, the presence of airway reflexes, the appropriate level of consciousness, and even some include hemodynamic stability and normal electrolytes and hemoglobin levels. But if you look at the values itself, they can vary widely, while for some trials, the screening include peak pressures below 25, for others, it is below 20. And this has implications in terms how early or late we do the SBT. And if we look at the SBT itself, the success rate hasn't been reported in all trials, but in those which have been reported is around 80%. Again, depending on how early or late we screen the patients. If we screen too late, there is no need of doing SBT. If the success rate is too high, the patient needs to be extubated. In terms of the SBT protocol per trial, we can see in the sandwich trial, that is the most recent trial, compare pressure support ventilation of 5 over a PIP of 5 versus usual care, that is no SBT during a 2-hour period. If you look at the successful extubation, the rate is surprisingly high, almost 99%, even though then reported an extubation failure of 10%, but without difference between the groups. And in terms of the primary outcome, that was the duration of invasive mechanical ventilation, there was a small difference of 6 hours in favor of the SBT group, but it is questionable what is the clinical relevance of this outcome. The Ferreira randomized control trial was done in a cardiac patient and used pressure support of 10 over a PIP of 5 versus usual care. And in this case, the SBT group has a higher successful extubation rate compared to usual care. That was, in fact, the primary outcome. And they also observed a shorter PICU length of stay in the SBT group. Foronda et al. In 2011 presented the result of another randomized control trial. In this case, was pressure support 10 over 5 over 2 hours versus usual care, that is no SBT. And in this case, there was no difference between the SBT group and the usual care group in terms of successful extubation. But the duration of invasive mechanical ventilation was shorter, the SBT group, 3.5 days, compared to 4.7 days in the usual care group. And finally, the only randomized control trial that compared 2 different modes of SBT, that is pressure support of 10 versus TPs. This showed that the rate of successful extubation was the same between the 2 groups, around 67%, and that was the primary outcome. And there was also no difference in terms of length of stay in the PICU and mortality, concluding that both methods are equivalent in terms of weaning children. So as you can see before, the clinical trials compare pressure support ventilation versus no SVT or TPs. But the question that remains unanswered is what is the most beneficial mode of SVT in children? Is it pressure support ventilation? Is it CPAP? That is the most common mode used, as you could see in the first slide. So there has been some observational studies, as you will see in the next slide, in which measure the work of breathing in the effort of breathing using different SVT, one with pressure support and the others with CPAP, and compare the work of breathing to post-extubation work of breathing, trying to answer the question, which is the best mode of SVT in children. As you can see in this study, they compare pressure support of CPAP and they use the pressure rate product, that this is a measurement that needs esophageal pressure monitoring, and it is in fact the result of the change in esophageal pressure multiplied by the respiratory rate. And you can see that both pressure support and CPAP had smaller or underestimate the work of breathing that the patient will have post-extubation. And in fact, a TP's SVT is the one that is more similar. Later studies, like this one published by Kemani group, that use again the pressure rate product as a surrogate of effort of breathing. You can see here in the whole cohort of 400 children that pressure support during extubation readiness test underestimate significantly the post-extubation work of breathing, while CPAP is closer to the post-extubation work of breathing. And this result remain when they exclude the patient with upper airway obstruction post-extubation. So this is another observational study that is against the use of pressure support ventilation as the SVT mode in children. And finally, a study done by DISC that measure the imposed work of breathing using a catheter inside the ET tube. And this graph shows the difference between CPAP SVT and CPAP with added pressure support in different age group, and there are 4 different ET tubes. And again, the CPAP or the addition of pressure support during the SVT reduce the imposed work of breathing. And this is the final observational study that is against the use of pressure support in the SVT in children. So if we take all of this together, so pressure support ventilation as the SVT mode as is associated with lower work of effort of breathing during the SVT, and therefore significantly underestimate post-extubation work or effort of breathing. The consequence of this, the underestimation of effort of breathing, may result in premature extubation and an increased rate in extubation failure. On the other hand, those who support CPAP, SVT, you can say that perceived high work of breathing on CPAP alone may result in delayed extubation. And if CPAP SVT delay extubation, this may increase the ICU acquired comorbidities related to longer mechanical ventilation duration. But in fact, there is no evidence to support longer mechanical ventilation duration during CPAP SVT. So when we talk about, or when we look at the duration of the SVT, this is again a study from the Kamani group that was done in 100 children with pediatric ARDS that underwent 300 SVT. So you can see clearly that there is a cluster of patients that fail during the first 30 minutes. Then minimal failure happens during the rest of the course of the SVT until the SVT is finished, in which the some of them are deemed failure just because it's at the end. So in other words, around 40% of the patients who would have passed a 30-minute SVT fail at 120 minutes, supporting a longer duration of SVT, around 2 hours, to more accurately assess extubation readiness in children. In the same study, and when they look at the mechanism of failure, the increased work of breathing and therefore a higher pressure rate product was the most important mechanism of failure in children. Remember, children with acute or recovering from acute respiratory distress syndrome. So now if we look at predictive indices for weaning, and we will take a look at 3 of them, starting with the rapid shallow breathing index. This was first described for adults in 1991, and it's basically the breath per minute divided by the tidal volume in liters. Was later on adapted for children, and this was done by Baumeister. And the adaptation implies dividing the tidal volume by kilogram. That is what we usually do in our pediatric clinical practice. So this author found a cutoff of 11 that differentiate patients who with successful and failed extubation, but you can see in the picture that there is significant overlap between them. Later on, Tyagarajan reviewed the RSBI index and find, while it really discriminates well between success and failure of weaning, the cutoff that differentiate successful extubation was much lower, around 8. Having said that, they also mentioned that for the neonates, so this younger population, the cutoff with the best predictive value was around 11. And a later study also found the cutoff of 8 as the best value of weaning index for successful extubation in children. In terms of the CROP index, CROP that stands for compliance, rate, oxygenation, and pressure, this is an integrative index that takes into account, as you can see in the equation, the dynamic compliance multiplied by the maximal inspiratory pressure and the multiplied by the arterial to alveolar oxygen tension, and all divided by respiratory rate. And this also was described in 1991 by Tobin as an index that includes oxygenation apart from measures of work of breathing. In children, the cutoff that initially was found to be helpful to differentiate between successful and failed extubation was 0.1. And if you can see in the graph, the discrimination is very good. Since failures occur below 0.1 and success, extubation success above. A later study found a slightly different cutoff of 0.15. but with, again, good discrimination in terms of success and failure of extubation. But this was not found in other studies that, in fact, concluded that these integrated indices did not reliably predict extubation success or failure in children. Finally, the situation is not much more different for P.1. So, as you might know, P.1 is the negative pressure generated in the first 100 milliseconds of an inspiratory effort against an occluded circuit, as you can see in the picture here. P.1 has been validated as a measure of respiratory drive in adults. And in fact, an elevated P.1, more than 3.5 to 4, has been linked to weaning failure in adults. So when we take a look at this index in children, there is much less data. And I brought here a recent study that shows that P.1 at 30 minutes after an SBT, that is more than 0.9, look how different the value is compared to the one reported for adult, is associated with a higher risk of respiratory support escalation post-extubation, among other predictive factors. We have done a study in children about P.1 behavior over the course of SBT with different pressure level, pressure support, and CPAP, and across all the pediatric age group. The result will be presented by Dr. Marchetto on December 1st in the e-poster session that I hope you can join. So finally, and in terms of international guidelines, the most recent pediatric ventilator liberation recommendation were published early this year, and I will summarize here the most important point. So, assessment of extubation readiness by a protocolized screening followed by an SBT is strongly recommended, even though it's ungraded. In terms of the SBT mode, CPAP or pressure support, in a standard risk patient, it can be either way. This is a conditional recommendation and supported by a very low certainty of evidence. But for those patients with higher risk of extubation failure, like the one listed in the table on your right hand, younger age, sorry, prolonged invasive mechanical ventilation, that means more than 2 weeks, chronic lung disease, chronic critical illness, pre-existing NIV, myocardial dysfunction, neurological impairment, neuromuscular disease, upper airway anomalies, genetic syndromes, previously failed extubation, or a borderline Piscine SBT. For this population, CPAP SBT is recommended. Again, this is a conditional recommendation based on a very low certainty of evidence, but the evidence cited is the observational study that I have described to you, which are against the use of pressure support ventilation because underestimate the work of breathing post-extubation. And finally, in terms of SBT duration, 30 minutes versus 60 or 120 minutes, depends on the patient risk for extubation failure, with longer SBT recommended for the high-risk group. Again, it's a conditional recommendation based on a very low certainty of evidence. So in summary, winning practice in children is highly variable, as you could see. Extubation readiness test, that means a screening followed by a spontaneous breathing trial, is currently recommended for pediatric patients. But what is less clear is what is the mode of SBT, whether it is pressure support ventilation or CPAP, with the latest recommendation favoring CPAP for patients with high risk of extubation failure. Predictive indices for winning, such as RSBI, the crop index, and P.1 are not used routinely in pediatric practice, and some of them have been found not useful in this population. And finally, international guidelines are based in low levels of evidence. So thank you very much for listening to this presentation. And if you want to know more about weaning and extubation, remember there is a scientific track on Thursday, November 30 from 11 to 12:20 p.m. And then what I already mentioned before, we will present the result of how children respond to respiratory muscle loading during SVT in the e-poster session Kids 2 on Friday, December 1st at 1:13 p.m. I leave you here my email in case you have any questions. Thank you very much, and I hope you enjoy CCCS.